Oh, hello September 2019. I didn't see you there. I was just enjoying the sunshine and having a coffee. I've had a couple of queries from you all about the lecture set. I've replied to some of you individually, but there was a couple of kind of clinical queries which I thought it might be easier just to record a video than try and type something out. So I'll do this and upload it to YouTube and put a link on Blackboard, which you've accessed it through if you're seeing this. So just go with it. First of all, apologies for one of the errors on my part, and congratulations to the eagle-eyed spotters of Bev, Rafi, Becky, Kerry, and many others who spotted the, I'd like to say deliberate, but not deliberate mistake of saying that for the e-learning that it was resuscitation level 3 for peds. However, those of you who've mentioned this have spotted that there isn't a level 3. So the paediatric ones was level 2 only. So apologies for that. That's entirely my fault from putting the wrong level on Blackboard when I did the announcements. Thank you to those of you who've fed back as well. I hope, as all of us here lecturing at the university, that sharing this information is useful to you. So any further queries, please do come back to me too. Or if there's anything you want to chat, I'll be in at Shrewsbury on various points. So yes, otherwise I hope to see you all soon. So the queries that I thought would be easier to answer. First of all, Jack emailed me to ask about intraosseous. Now I can't remember off the top of my head how much detail I went into this on the slides about. But when patients are sick, particularly if they've been hypovolemic for some time and deteriorating, the blood vessels in the peripheral system all clamp down. So the blood flow gets diverted back into the centre of the body towards the heart and the brain. Yeah, got that the right way around. Heart and the brain. So trying to then cannulate that patient or anyone in cardiac arrest is really, really difficult. You see people do it and they might get it in 1 or 2 attempts, but they make it look easy. But it's really difficult, and that's the kind of physiological reason why it becomes difficult. So intraosseous is something, it's been used in paediatrics for years and years and years. Because children, of course, have smaller veins, they compensate for longer, so they shut down much more as well. So what IO does, intraosseous, is goes into the bone. So the bone for me, I think as a student, sat on your side where you were, I didn't really think too much about bones. I thought they were just something that you basically hung all your muscles and tendons and all that jazz off. But they're living things. So bones, the way that they can repair themselves, the way that they can churn out all of the blood cells and essential things that our body needs, is because they have a really good blood supply. And because it's a bone, because it's a solid structure, it's non-collapsible. So the intraosseous driver, if you wanted to look more up on this, you could search for EasyIO. Teleflex, EasyIO, that's the company who manufacture these, and they have tons of learning equipment, learning videos and resources and things on their website. What the driver does is you attach a needle to the end, and that depends on what bone you're going into. Generally, the best place is in the proximal humerus, so the head of the humerus here, or the tibia is the other place that is also used. But the needle is selected that's long enough to get through the tissue and just go into the bone underneath. So in terms of the structure of the bone, there's a thick outside, which is probably about 5 mil at most. It's called the cortex, and inside that is the medullary space. That's where the marrow is, and that's where the blood vessels kind of feed into. Excuse me, some of you might know this trying to learn at home. Same for working, that there is often toddlers with kittens being brought to you. Oh dear. So yeah, that's intraosseous. The needle goes into the medullary space where whatever's infused can then be picked up into the main circulating system. It's just as effective as IV, so it's essentially the same as doing IV. It's just it goes into the bone before it then goes into the veins from there and into the system. So for any of you who may be placed in critical care areas, it's something that you are likely to see, and as time goes on it's being used more and more, not necessarily just in cardiac arrest as well, in patients who are deteriorating and sick where we want to get access and treat them quickly. So that is IO. Again, tons of resources on the YouTube staff's page. There is a video done by the paramedics. that you can access if you wanted to get a bit more information, so it gives you an introduction. But again, Teleflex, easy IO, lots of videos and stuff on there, if that kind of stuff floats your boat. Other question was about the practicalities of resus during COVID, CPR during COVID. Now it was quite difficult at the moment because we're kind of in a hinterland of, we haven't got full new guidance that's going to be in place for the next 5 years from the Resus Council as yet. But there is some that was issued during COVID. However, because as patients' numbers, we're a bit hotter on testing now. We have high and low probabilities as to whether patients have COVID in hospital. Sometimes there are different approaches being adopted by trusts. So, just to summarise, out of hospital, which is where if you're doing CPR, if you're discovering someone collapsed, it's probably where, as students, you'll be coming across it. Just to re-emphasise what was on the slide, you check for danger, including thinking, how likely is this person to have COVID? How safe am I, prior to that? Check for response, so shake the shoulders, call the name, shout for help, get people coming to you. Now, for a standard patient with the doctor's ABCD, we do an airway and breathing check and get down close and listen. However, with COVID, as I mentioned in the slides, we don't open the airway, we don't get close, because obviously we're going to be exposing ourselves then to someone who could have this, if it's a stranger. So what we'd suggest is standing back, observe the patient, and just see if there's any signs of life, and if they're making efforts to breathe at all. So that is it. If there hasn't been an emergency call placed, do it at this point. And before you start CPR, so compressions, the side of CPR, cover the patient's face with a mask or some kind of cloth covering, the same as everyone's wearing out and about now anyway. And it would be that you just do compressions. So unless it was someone that you knew, someone who you'd been exposed to, them breathing, you could do mouth to mouth in that circumstance. But as a general rule, just do compressions only if you're attending an out of hospital emergency at present. In hospital, again, it's slightly different. I put the link to the COVID guidelines from the Resus Council, which were put in place at the beginning of the pandemic to ensure maximum staff safety. And the general rule is that if someone has a cardiac arrest, that you don't start compressing that patient until everyone has level 3 PPE on. Now, level 3 PPE, if you're not familiar with the term, is FFP3 masks, or a properly fitted one with a visor, with a full gown, and with gloves on there too. So you wouldn't start compressing until that was on. The rationale being that there's a debate about this. I could talk forever about it, but the debate going on is that as you compress the chest, it could create aerosol generating. It is classed by some experts, but some not, as an aerosol generating procedure. Aerosol are the finer, minuscule droplets, which are less likely to be picked up by a standard mask or face covering, and will only get maximum chance of protection from an FFP3. So yes, that's been slightly difficult. A lot of staff, it's been very emotive in the trust, because it's like, well, I've identified someone in cardiac arrest and I just stand there putting my gloves and apron on. But of course, you've always got to think about your own safety. Once everyone was gowned and gloved up, you could start CPR, and it would be then 30 to 2. However, everyone would be in full protective gear, and if they were doing the ventilations, it's likely to be that they'd still be using the bag valve mask, as was mentioned in the session, and you'll practice in the skills lab too. It's just that it'll be definitely 2 people, 1 person getting the best seal possible between the mask and the patient's face to reduce spread of stuff as they exhale, and also a filter would be fitted on there too. What could happen in the interim is that if you're waiting for a team to put their gear on, whilst you couldn't start CPR, what has been suggested in terms of the guidelines at present is that you could attach the pads and use a defibrillator to see what rhythm the patient's in. So whilst you can't do CPR, you could see if the patient was in a shockable rhythm and deliver the shock. I say you, I'm talking about the in-hospital resus teams. Of course, it's not something we'd expect you to be doing at this point, in hospital at least. So some trusts are moving away to having high and low risk, some where you might start CPR, some not, but it's really difficult. So hence, I just re-emphasise now, when you go into placement, check your local policy, check your mentors, speak with the resuscitation team who will be able to guide you through what happens in that current trust if there is a patient who suffers a cardiac arrest. I'll just check my list again. I think that's answered the questions I've put on there. So I hope it's been useful. As before, ping back anything to me if you've got any questions. Don't get hung up on the nuances though. And we'll see you in the skills lab to practice this skill. I look forward to meeting you all. Thank you for your feedback. And I'd best go and check that my toddler and kitten aren't running amok. All the best, September 19. See you soon.